Respected chairpersons, teachers and colleagues, sincere thanks to Dr. Manikandan for this great opportunity. Entire tachyarrhythmias in 20 minutes, well, you can cut off my slides sharp at 20 minutes. I don't know whether I'll be able to complete it, but be strict with time. Okay. So I will first say, there are two types of tachyarrhythmias, narrow and wide QRS tachycardias. As practicing physicians, when you see a wide QRS tachycardia, the best is you revert with a synchronized DC shock. That's the safest for you, rather than giving some drugs which can kill the patient occasionally. And refer immediately to a cardiologist, that is electrophysiologist, because next time the patient may not come alive to you. That's the danger of a wide QRS tachycardia, because 80% of wide QRS tachycardias are VTs unless proved otherwise. So my stress will be on narrow QRS tachycardias. So I had an emergency call from the TMT room. The patient is in tachycardia. So I'm not going for a, because of the lack of time, I'm not going for an interactive session. So what happens here is the lowermost tracing is only the true ECG, that is a raw rhythm. Rest of the things are computer synthesized, the filtered data. So the AI of the treadmill synthesize its own rhythm. So the first take-home message is, before shocking, before giving the drug, examine the patient, count the heart rate or pulse rate, and make sure that it is a tachycardia. So beware of artifacts. Now this patient recently transferred from casualty, diabetic, admitted with altered sensorium. Of course, he had acidotic breathing. So any patient coming with any symptom other than labor pain will have an ECG, immediately. So ECG was taken, which showed this rhythm. Patient was given IV diltiazem and metoprolol. Patient was in hypotension, transferred to cardiology. Of course, the cardiology duty PG is a good physician basically. So he found the patient had a acidotic breathing. The blood sugar was 500. The ABG showed metabolic acidosis, so he diagnosed ketoacidosis, and there was a bronchial breathing in the right infraaxillary area. So this is atrial fibrillation, this is a irregular narrow QRS tachycardia. When it is fast, you can miss the irregularity. So the second take-home message is, treat the patient and not the arrhythmia. Okay, so especially in elderly, atrial fibrillation can be a manifestation of conditions like pneumonia or sepsis. So don't go after it. If you give drugs, the patient will ultimately go to shock. Okay? So don't over-treat arrhythmias. Hemodynamic instability need not be due to arrhythmia. Make sure that patient doesn't have other causes like hypovolemia, hemorrhage or sepsis or pulmonary embolism before treating it. Treat underlying cause, and treating the compensatory tachycardia may worsen the situation. So a rhythm abnormality plus hemodynamic instability doesn't mean that this situation is caused by arrhythmia. One clue is, if the heart rate is less than 150, most likely it is some other cause, but if it is more than 150, probably the arrhythmia is the villain. Now, a few days back, I got this case. Now this indicates the complexity of diagnosing arrhythmias. A patient was managed in periphery with IV adenosine, IV beta blocker, IV amiodarone, and 3 shocks. Despite that, the arrhythmia is persisting. So again, I'm sure there are postgraduates. Anybody? What it is? The V1 shows RBB morphology. The axis is left. So this is called Bell-Hassan's VT or verapamil sensitive VT. So there are case reports that even a DC shock need not revert this arrhythmia. So this is a complexity of sharply diagnosing the arrhythmia. So this patient, the postgraduate, gave IV verapamil, and the arrhythmia immediately subsided. Whereas if you give verapamil to other VTs, you can kill the patient. Okay. So tachyarrhythmias can be narrow QRS less than 120 milliseconds, wide QRS more than 120 milliseconds. It can be supraventricular or ventricular. It can be hemodynamically stable or unstable. Now, certain tachycardias doesn't require AV node for its maintenance. For example, sinus tachycardia, atrial tachycardia, fibrillation, flutter. These are occurring above the AV node, whereas certain arrhythmias require AV node for the maintenance of the arrhythmia. For example, AV node reentrant tachycardia, that is AVNRT. Then AV reentrant tachycardia caused by a bypass tract or junctional tachycardia. These require AV node. So this is called AV nodal dependent tachycardias. Now some points as physicians you have to remember always is whenever the tachycardia is very fast, the irregularity can be easily missed. Similarly, slow AF irregularity can be missed. Then there can be patterns of irregularity. For example, a flutter when it develops Wenckebach periodicity, it can be regularly irregular. Same arrhythmia can manifest as a regular and irregular. For example, flutter usually conduct as 2:1. So it will be 150. So fast tachycardia at 150, always suspect flutter. Exact 150 heart rate, you always suspect flutter. Now it can be varying block leading to irregular pulse. Now the basic dictum is whenever the impulse comes from atrium through AV node through the His bundle down to the ventricle, it will always produce narrow QRS. Whenever this rule is broken like this, there is a pre-existing bundle branch block or an accessory pathway, or when the impulse arises from the ventricular myocardium, it will be wide. Okay. So SVTs are usually narrow QRS. It implicates the conduction is coming down via the normal conduction system. But one caveat, suppose a VT is arising from the septum near the vesicles, the impulse will quickly go through the vesicles and it can appear quite narrow. The one which I showed you, the vesicular VTs can be very narrow and can be misleading and confusing. It can be very complex. You see, the first part is a wide QRS, then it quickly goes to narrow QRS tachycardia. This is actually a bypass tract. Now, a bypass tract induced tachycardia can be both narrow as well as wide. For example, if it comes down via the normal conduction system, it will be narrow. It is called orthodromic AVRT. So, if it comes down via the accessory pathway and go up via the AV node, it will be wide and it is called the antidromic. See the spelling? It is not ANTE, it is ANTI. Okay, antidromic AVRT. So, whenever you see an arrhythmia, you always go stepwise. You first act what is the atrial activity. Rather than looking the ECG like this, your head will be oscillating up like a pendulum. Don't do that. So you just look at the atrial activity. What is atrial activity? P wave. So only look at the P wave. Forget the rest of the thing. Is it present or not? If it is there, is it a P wave, flutter wave or fibrillary wave? Now what is the rate of that atrial activity? Is it regular? Next question, is the morphology normal? Is it a sinus P wave or is it an inverted P wave in 2-3 AVF, which will tell you that it is arising from below the focus. Now after completing the atrial activity only, you see the ventricular activity. Again go rate, regularity, whether it is narrow or wide. If it is wide, is it an RBB morphology, LBB morphology? And the next question is it constant or varying? For example, one beat may be in RBB morphology, next beat it will be LBB morphology. So the moment you see that, you diagnose bidirectional tachycardia. Okay, it may be a manifestation of digitalis toxicity. Now at the end, after seeing the atrial and ventricular activity, you see what is the AV relationship. Normally each P wave is followed by a QRS. So A can be equal to V wave. In some conditions, the atrial rate will be more than the ventricular rate. And extreme rare situations in a narrow QRS tachycardia, ventricular rate can be more than atrial rate. This is given in Brown world. You can go and by heart it. So A is equal to V is the most common scenario. The moment you see this, the next question you have to ask is what is the relation between the R wave and the P wave? If the P wave immediately follows the R wave, it is called a short RP tachycardias. And if it is far away from the QRS, beyond the T wave, it is called a long RP tachycardia. The only way to remember is by heart it. Okay, by heart, and you can even keep it in your mobile to see the DDs. So now let us analyze the first case which was managed in the casualty. Okay, so you look for the atrial activity. So you don't see a P wave anywhere. So I have marked two areas where you see multiple small waves, that is fibrillary waves. So the first step itself, you diagnose it. First question, is the atrial activity present or not? From that single question, you know that this is atrial fibrillation. Okay? Now, regular narrow QRS tachycardias can be AVNRT, AVRT, atrial tachycardia, atrial flutter, atrial fibrillation, or multifocal atrial tachycardia. Then whenever the atrial rate is more than 100, it becomes supraventricular tachycardias. AVNRT and atrial tachycardia require tissues above the AV node. It doesn't require ventricular myocardium, whereas AVRT requires both the atrial as well as ventricular myocardial tissues. Now look at this, patient's pulse rate maybe 60, okay. But see the atrium, what is the atrial rate? It is around 300. So atrial tachycardia is going on. So it's not the pulse rate alone which matters. So the three things, AVNRT, AVRT and atrial tachycardias forms the majority of the tachyarrhythmias. Now this is what I told you about short RP and long RP tachycardias. Again, you have to by heart this, only then you can have the DDs. The typical example of a short RP tachycardia is AV nodal reentrant tachycardia, and a long RP tachycardia is atrial tachycardia. I am not going to the details of others, you have to by heart it. Now, during the evaluation, before you see the ECGs, you have to look at the patient. More than 98% of patients with a previous MI, it will be VT. Only 7% of patients with SVT gives history of acute MI. If the duration of tachy is more than 3 years, more likely to be it is SVT rather than VT. Now, head to foot examination is a must for anything in clinical medicine. This is a thing which we have published in Circulation. You see the hair of a lady and see the palms. So it is look like a black American's hair, isn't it? So this is a curly hair, palmoplantar hyperkeratosis. Now this is a condition called a Naxos disease. We have seen only one case in the entire department over this many years. So the one thing which is confined to the Naxos island, reported from Calicut also. So anything you may be able to see. Now, as physicians, you might have seen periodic paralysis. The same patient may come later with an episode of syncope. There is a deadly dangerous condition called the hypokalemic periodic paralysis with a long QT called Anderson-Tawil syndrome, very high mortality. So minor facial abnormalities, bony abnormalities may be the clue for it. A bifoot uvula may be there. So this is BMP2 mutation producing various arrhythmias, showing various skeletal anomalies. So what I am highlighting is not only the ECG, the head to foot examination may give a clue to you that this is probably a very dangerous arrhythmia, a genetically mediated arrhythmia which you are managing. So in relatively stable patients, before ECG analysis, get relevant history. You see the pulse, see the JVP, see S1 whether it is constant or varying. So irregular pulse, AF, multifocal atrial tachycardia, flutter or atrial tachycardia with varying block. Varying pulse volume, if the rhythm is irregular it is AF, if the rhythm is regular it is VT. JVP, look at the JVP, if it shows Canon waves, if it is regular it is SVT, irregular it is VT. Then S1 varying, it can be atrial fibrillation, multifocal atrial tachycardia or VT. Then if the S1 remains constant, it is SVT. So just by looking at the pulse, JVP and S1, most of the arrhythmias can be diagnosed at bedside. Okay. So I can give the slides to them, those who want we can take this. Now look at the JVP. What you see is regular Canon waves. The commonest is AVNRT. Okay. Now see regular Canon waves. Look at the neck from a distance and you get the diagnosis. Okay. Now this is what is called a Fro positive in AVNRT. Now just see the carotid massage. I will tell this is exactly the way a carotid massage should not be done. Okay, this is a throttling. Anyway, that disappeared. Now see the JVP carefully. A tachycardia is going on. Is it regular or irregular Cannon wave? Irregular. Okay. So it is a white QRS tachycardia. Why you go after all the difficult algorithms? Just see the patient's neck. It shows AV dissociation and it is ventricular tachycardia. It is. So don't waste too much time on the ECG. See the patient also, which will be helpful. Then a detailed history is essential. 3 generations of history must be taken. We recently had a 30-year-old boy with 20 family members died due to sudden cardiac death. Ultimately turned out to be lamin AC mutation. So family history is very, very important. Then the company which it keeps. Now valvular heart disease, pulmonary disease, hyperthyroidism, post-operative situations, you know it is atrial fibrillation. Pulmonary disease, multifocal atrial tachycardia. Okay, structural heart diseases, you have to suspect atrial flutter or fibrillation. Then structurally normal heart, usually it is AVNRT or AVRT. In congenital heart diseases like Epstein's, corrected TGA, HCM or AV canal defect, there can be bypass tracts which is associated with it. Now, flutter is more common in males, AVNRT is more common in females. AVRT first episode occurs 10 years younger than AVNRT. Now in children, if there are any pediatricians here, 80% of SVTs in children are actually bypass tract related tachycardia, that is AVRT. Okay. Now onset and offset, if it is a sudden onset and termination, it can be acute AF or flutter, but usually AVNRT or AVRT. Then there can be gradual onset and recession. Then there is something called warm up and cool down. Suppose the patient say the palpitation starts, go on increasing, the rate go on increasing. It can be focal atrial tachycardia or junctional tachycardia. Now rushing through a few ECGs. If I am exceeding time, please switch off. Now just first question, is the atrial activity present or not? Look from one end to the other, you see fibrillary waves. From the first step itself, don't look at any other thing, don't look at the QRS. It is atrial fibrillation and this is how the atrium is fibrillating. Okay, now you see a narrow QRS tachycardia. When the rate is very fast, you may think it is regular, but very carefully look, you see irregularity. Not only that, you see the voltage is very high. There is a family history of sudden cardiac death. His younger brother has died. So he was asymptomatic till then. So sudden AF, hypertrophied heart, patient going into heart failure. So this is how atrial fibrillation destabilizes a patient with HOCM. Okay. Now again, first question, is the atrial activity present? Normal morphology, is it constant or varying? You see 3 types of V wave. So from the first step, that step itself, you know that this is a multifocal atrial tachycardia. Now, you see a narrow QRS tachycardia. You see at the end of the QRS complex, there is a sharp deflection down. So this is called a pseudo S wave. That is a P wave occurring at the end of the QRS complex. This is what I call a short RP tachycardia. Now this finding, a pseudo S wave in 2,3 AVF is 100% specific for AVNRT. So if you find this, it's almost sure that it is AVNRT. Now a 55-year-old male, sudden onset palpitation, TRO positive, reverted with adenosine. Diagnosis given in the discharge book is ACS enstomy with this SVT. Don't write this. Okay. Any tachyarrhythmia can have TROPI positivity. Okay. So a TROPI positivity after a tachy doesn't mean that it was an AC. If the patient had no chest pain, don't put this diagnosis. This will unnecessarily drag the patient to coronary angiogram, and there may be some lesion in the diagonal, and people will put a stent in it. So don't do this. So a rate-related ST depression is much higher in the bypass tract-related tachycardia, that is AVRT rather than AVNRT. Now, okay, I will show a few more ECGs and then stop. Now, see this female with mitral valve collapse MR on follow-up, recurrent palpitation. So, the first question is the atrial activity present or not? So, you look at the atrial activity, you see that it is inverted P wave in 2-3 AVF. Now, what is the relation between the R wave and the P wave? It is far away from the R wave, that is long RP tachycardia. Now, I have told you at least one thing to remember in a long RP tachycardia, that is atrial tachycardia. Now, this, if you see it in a young child, that is a young boy, 5-year-old or 6-year-old child with a dilated cardiomyopathy, you are highly likely to misinterpret it as sinus tachycardia due to heart failure. Now, this is a condition called PJRT, that is permanent form of junctional reciprocating tachycardia, where you see inverted P waves in 2-3 AVF and the RP interval will be quite long. This is an incessant tachycardia, and if you ablate the junctional accessory fiber, it will be a permanent solution. So, if you don't do that, the child will go on developing deterioration of the LV function, and finally you will label the child as DCM, whereas it is potentially curable. So, these things must be kept in mind. I think I have exceeded 20 minutes. So, I have not touched the white QRS tachycardia because I already told you, whenever you see a white QRS tachycardia, 80% is VT. When we are managing in the periphery, the safest is you do DC cardioversion after sedation and send the person, don't keep, because next time, next episode, the person may not come to you alive. This can lead to medico-legal issues. Okay. Now, a person coming to a physician with a white QRS tachycardia, if you see very carefully, you know that it is slightly irregular. So, it is a pre-excited AF. Yeah, this one. This you have to register into your brain. A white QRS tachycardia, but if you see carefully, the RR interval is varying. Now, if the blood pressure of the patient is stable and you give any drug like IV verapamil, diltiazem, beta blocker, or as per the most recent criteria, amiodarone, you can kill the patient. Okay? So, this will block the AV node, and the entire impulses, atrial fibrillation impulses will go through the accessory pathway into ventricle, and you will precipitate ventricular fibrillation. So, this ECG can be shown in the examination and asked, the patient is stable, what will you give? Okay. If you say beta blocker, IV beta blocker, diltiazem, verapamil, then they will tell you come after 6 months, because you are going to kill the patient. Okay. So, if you are not sure, that is why I told you in a white QRS tachycardia, if you are not sure about the diagnosis, the safest treatment is a DC cardioversion after sedation. So, this is one thing which you have to, in the white QRS tachycardia spectrum, this is one thing which you have to register into your brain. Never forget, that is pre-excited AF. So, irregular rhythm, varying QRS width, and this should never be forgotten. And if you ask me, if the patient is hemodynamically stable, what is the drug of choice? It is ibutylide. It is available. It is around 1,000 rupees. It is available for all of us. Propafenone is not available, but ibutylide can be given for this. But no other drugs, including amiodarone. Previously, we all used to do, but there are plenty of case reports of precipitating VF when you give amiodarone to this entity. So, not even amiodarone. Thank you so much.
Thank you, Dr. Rajesh. I think for most physicians, deciphering arrhythmias, especially tachyarrhythmias, is often a very difficult problem. Dr. Rajesh has been a good guide. വാസ്തവത്തിൽ പണ്ട് കുട്ടിക്കൃഷ്ണമാരാരുടെ ഭാരത പര്യടനം വായിച്ചു കഴിഞ്ഞപ്പോൾ ഉണ്ടായ പ്രതീതിയാണ് ഈ പ്രസൻറ്റേഷൻ കഴിഞ്ഞപ്പോൾ എനിക്ക് തോന്നിയത്. താങ്ക് യു.
Rajesh is an inspirational teacher and is mentoring a quite large number of young cardiologists. But just like what Professor Wilson said, don't worry about deciphering white curve, whether it is a aberrancy or VT. As Rajesh said, if you are in doubt, best policy, even if there is no hemodynamic compromise, cardioverted and even the experts make mistake. 30% there are mismatching when interpreting. So don't you worry about that. There was something called adenosine test. Are you doing? I mean, is it scientific?
Yes, sir. So, see, when you are seeing a tachycardia, when you give IV adenosine, there are two types of responses. Either all or none. That is, it can respond. That is, AVNRT, AVRT can be reverted. But one type of ventricular tachycardia can also be reverted. There is something called adenosine sensitive VT, which arises from outflow tract of the ventricles. That's one thing. Whenever you give this adenosine, you should switch on the rhythm recording. So sometimes what happens is it transiently slows the AV node and the flutter waves or the P waves, which are at a rate of 300, gets exposed. So the mechanism of tachyarrhythmia become obvious. So the only thing is you have to go on recording. So the atrial flutter waves can be exposed. Then multifocal atrial tachycardias or focal atrial tachycardias, the P waves can be exposed by giving adenosine. The same can be given by giving carotid sinus massage also.
Thank you, Rajesh. I came later part of your talk, but I really enjoyed it. Now, when I saw the title of your talk, I thought I was expecting lots of ECGs, lots of P wave measurement, PR measurement, RP, QRS duration, all these measurements and all. But you did that. But along with that, the beauty of your talk was that you gave lot of clinical scenario. I mean, more important than the ECG, you stress that physical examination, symptoms, the way they present, and the analysis of those presentation gives you more clues sometimes than what an ECG will reveal. That is the take-home message of your talk about this. That is what I thought. So thank you very much.
Thank you, sir. When Manikandan asked me to cover entire tachyarrhythmias in 20 minutes, I was wondering what to do. To read Ramayanam, we have entire Ramayana Masam. Oru Masam mottondu. Then how can you cover all the tachyarrhythmias in 20 minutes? I was wondering. So I thought white QRS tachycardia I will finish with one sentence. That is, white QRS tachycardia is VT unless proved otherwise. 80% time you will be correct.
Thank you.